So apparently I'll be introducing Adam Friedman. He's a professor and chair of dermatology. No. That's up here. Ooh, this is how many of you guys were so excited to see me for the last talk that wanted to just come see me for this talk? We've got like 4. Good. That's nice. For some reason, you guys did shortchange me. I only have 28 minutes. I want my 30 minutes. I am going to introduce myself because no one does a better job than me. I'm Ben Lakshan. I'm a dermatologist in the Washington, D.C. area. I run our clinical trial center and psoriasis treatment center. I've had the privilege of working with AbbVie, amongst many others, in this space for psoriasis. It's something I love to do, especially because I've got great drugs that make me look good. I'm talking about the biologics, not that EDM thing that's going on right now. So clear horizons. This is the inaugural showing of this deck. So I will be the first one presenting this. So if you guys are going for your Pokemon cards and trying to collect all the drug talks, this is the newest promotional deck that you guys can knock off the list. The speaker disclosure slide is something that I like to think of as a consent process during clinical trials. I can't enroll anyone in a clinical trial until I consent them. I can't start with the talk until I read my AbbVie sponsorship disclosure. This program is sponsored by and on behalf of AbbVie. The presentation contents are consistent with all applicable FDA guidelines. The speaker, that's me, for this program has been selected by AbbVie and is presenting the program material on AbbVie's behalf. Okay, let's get this party started. Any of you guys used SKYRIZI before? Okay, got a couple of hands, yeah, cool. As you know, it's indicated for moderate to severe psoriasis. We'll talk about the safety a little bit later throughout the deck. Let's hop into the objectives. So we want to understand, obviously, the treatment goals of managing patients with psoriasis. We want to review that pivotal phase 3 data, as well as the long-term data of the product, and really explore additional evidence across trials with real-world patients. And I think the real-world component is as important to complement what we see in the clinical trial data as the clinical trial data itself. NPF data of over 5,000 individuals from 2003 to 2011 actually shows what we all already know. Very, very high rates of patients consider psoriasis to have a major impact on their quality of life. Okay? Over 90% of them suffer from itching on a regular basis. Over 4 out of 5 patients experience pain on a regular basis. And close to 90% of the patients experience anger, frustration, they're self-conscious of their disease, all because of their psoriasis. It's nice to see this, to validate what we already know and experience from our patients. So the treatment goals, well, obviously we want to learn, and hopefully it's my job to have a balanced conversation looking at the efficacy, the safety, talking about the dosing frequency, and really the confidence in therapy, as well as the partnership with AbbVie and the support services they provide. So let's jump into the clinical trial data. So actually, before we get started with that, the mechanism of what sets this MOA apart. This is an IL-23 product, and IL-23 acts on Th17 cells and also drives and motivates the IL-22 cells as well. It really induces them to be the pathogenic Th17 cells producing IL-17A, F, TNF-alpha, etc. Okay? What it doesn't do is it doesn't block IL-12. So it binds to the P19 subunit, binding to IL-23, blocking that lower cascade. Is this like written into your brains from the reps over, over months, weeks, years telling you? Well, what we see is that this is a product that is incredibly consistent. This is as good as it gets in terms of clinical trial data. Unbelievable reproducibility of the Ultima 1 and 2, where 3 out of 4 patients achieved a PASI 90 score. Okay? We have over 4 out of 5 of those patients are clear or almost clear after a baseline of having moderate or severe disease. But really, where's the money? It's all the comparative data, and we're going to see this in a little bit. Why is it good to have an active comparator? Anyone want to shout out? There'll be prizes at the end. I can't promise dessert because you guys have already had dessert and lunch, apparently. Well, an active comparator is good for 3 reasons. One is you want to see, in a head-to-head fashion, is it more effective than said drug that's already on the market? Makes sense. 2 is you want to ground your data. What does that mean? Well, from this EU-sourced ustekinumab, okay, what we see is that the data in the Ultima studies almost identically parallels what we saw in the pivotal phase 3 Janssen studies of this product as well, validating the numbers that we see with SKYRIZI. And what we see is over 30% of the patients at week 16, 30% more patients achieved a PASI 90 from SKYRIZI over Stelara or ustekinumab. And then as you go out even further, what we see is that delta gets even wider, where over 80% of those patients achieve a PASI 90 of the year, and less than half of them with SKYRIZI, and with Stelara, pardon me. And then let's up the ante, okay? I think that's an appropriate terminology here since I've been wickedly unsuccessful at the craps tables. But upping the ante is, let's look at PASI 100. PASI 100 makes a lot of sense for us. It's very hard for people to understand what a PASI 75 and a PASI 90 is if they don't do clinical trials. But a PASI 100 is easy. 100% clearance, 100% reduction of PASI score, patients are completely clear. What we see at week 16 is over twice as many patients, over 40% of those patients are completely clear at 16 weeks, compared to 18% with ustekinumab, and then going out to 52 weeks, close to 60%, with just about a quarter of the patients on the Stelara arm. So over twice as many of those patients are completely clear. And what we know is from patient surveys is that clear means a lot to these patients. Lots of different ways to chop up this data, okay? And what we see is this is the open label extension in this darker blue component. So how do the patients do it a year? Well, they moved into open label, and what we see is horizontal lines no matter how you cut that data, okay? You look at the data in terms of just the modified NRI, the last observation carried forward, or really just how the patients perform just in the real world. And what you see is these lines literally parallel each other and overlap each other, meaning no matter how you look at the data, these are pretty much the same. The limitation is there's potential enrichment of long-term data, meaning that the patients that drop out of the study may not have been performing, lowering the denominator in some of the statistical analyses. And looking at PASI 100, same thing as well. Mean PASI improvement. So this is how your patient is going to do, and this is the closest way for me to say how my individual patient's going to do. So it takes all comers. And what we see is, crazy deep fake technology that AbbVie has embraced this is not a real person. Apparently this is not a real pointer either. But this is not a real person, but this is representative of what these patients look like at that improvement score. So at baseline, expect the average psoriasis patient in this study to look like this. We go out, what we see at week 4, significant reduction, so mean PASI improvement, 57%, and that's what you can imagine to look like, and I think my patients look pretty similar to that. You go out to a year, and what we see is a mean PASI improvement is 96%. And what that means is everyone's kind of clustered there at the top, okay? So if there were a few patients that were minimal responders or non-responders, it would drag that number down. So having that gives you the assurance that if you put a patient on this drug, chances are they're going to do pretty darn well. And over time, week 232, out a few years, what we see is that it looks pretty much the same. So there are a couple of different head-to-head studies we see. We already talked about the Stelara SKYRIZI head-to-head. So we've got SKYRIZI, a IL-23 against an IL-12-23. Then we have an IL-23 against an IL-17A. And then we have a ombre on ombre, brother on brother fight here, SKYRIZI versus Humira, okay? So let's just delve into this. We already covered this earlier, but what we see is no matter what endpoints you look at, PASI 90, PASI 100, or PGA of 0 or 1, SKYRIZI outperforms STELARA. I don't need to repeat what we already covered. Let's switch gears to the Cosentyx head-to-head data. And once again, we look at all measures at 16 weeks and 52 weeks. A significant proportion of patients perform better on SKYRIZI versus Cosentyx, especially as you raise the bar. As you get closer to perfection, the delta gets wider. And as we see over time, the SKYRIZI patients aim for the sky, and the Cosentyx patients, the efficacy starts to go, diminish on those graphs, which we can't see in this slide. And secondary endpoints looking at PASI 75, PGA 0/1, and PASI 100, all are consistent with what we saw with the primary endpoints. And then looking at Humira, and once again, I think these head-to-head things are important in terms of efficacy, but also important in terms of safety data as well. So going against the TNF-alpha inhibitor, another AbbVie product, what we see is the data from the pivotal phase 3 studies for Humira are almost identical to what we see here in terms of the PASI 90 scores. We see 72% on SKYRIZI versus 47%, less than half of those patients on Humira. And going out to PASI 100 in the pivotal phase 3 studies for Humira is about 1 in 5 patients, pretty consistent with what we see here, and we see 4 out of 10 patients are completely clear at 16 weeks in this study. So let's talk about real-world patients, and actually I'm going to highlight a couple of these, but not all of them for the sake of time, since I only have 16 minutes and 34 seconds left. Can we pull up the gentleman with the elbows right there? That's pretty impactful. I mean, this changes someone's life. How many of you guys get bummed out by having a zit, on your face? It bothers me. Maybe I'm just shallow Hal or something. But, imagine going around like this. Just the cosmetics alone would concern you, but remember, there's a lot of inflammation that's boiling under the surface. So I think that's unhealthy as well. There's skin everywhere, so if he's going to, commit a crime, there's DNA everywhere. It's very embarrassing for people. I'm sure he hasn't gone to the pool in years. This guy is thrilled. He's giving you a hug. He's posting things on Yelp and saying you walk on water, but I obviously take all the credit, but the reality is that the drug's doing the lion's share of the work. I just happen to be smart enough to utilize that. Can we also look at that shin? Because I do think that medications work better from top down. Top's easier. Legs tend to be very tough to treat. This can interfere with ambulation. But, I mean, this is amazing. She goes, not only does the psoriasis clear up, but she goes from 1 leg to 2 legs, which is unbelievable. I'm not attesting that it actually has an effect on generating legs. And then the last one is the top gentleman. I'm only doing this because I love Lindsay, and she's in my group, and this is her patient right here. They're down in Arizona, so he's obviously working on his summer tan, but we see a significant reduction. But it's notable that he does have some post-inflammatory hyperpigmentation, the shadows of old psoriasis, which does fade over time. And as I think we get a better understanding of appreciating skin of color and the effects on multiple different skin types, be cognizant of the fact that the darker the skin, the more likely they are to have persistent pigmentation that can linger for months to years. Okay, we'll switch to the next one. There we go. So I really talk about things in an upside-down fashion regarding these decks. I prioritize the safety more than the efficacy for this product. The efficacy speaks for itself. I think in my eyes, I've done everything I can to show you, how well it works. But really, it's an arms race in terms of efficacy. What sets this apart in my eyes is the safety. And what we see is the talking points that at least resonate with me. Because what I want to do is I want to leave that room with a patient, educate them in an effective manner that they feel that they got a incredibly focused encounter, that they understand the risks and benefits, and I do it in a very concise way. And I think that with this product, I can get out of the explanation of this medication in 30 seconds. And it's very easy. No labeling warnings for IBD, malignancy, depression, candidiasis, okay? No routine lab monitoring, okay? Real or perceived, that resonates with patients. That resonates with me. I was like, that's pretty nice. What we see is that there's no signal for active tuberculosis. I like these tables. They get a little complicated, but what we see also, Stelara from the SOLAR registry for years was touted as the safest biologic in the psoriasis space. So to use SKYRIZI as a comparator against Stelara, what do we see? We see 0.4 in the SKYRIZI category to over, what is that, 4 times as much? My math, 5 times as much? 4 times as much with Stelara. So the rate of serious infections is significantly greater in this 16-week period on Stelara versus SKYRIZI. Serious adverse events, twice as many serious adverse events with SKYRIZI with Stelara over SKYRIZI. And carrying on, injection site reactions, I think both are tolerated pretty well, but less than half the rate with SKYRIZI compared to Stelara means a lot to me. No signal for IBD like we talked about. Deaths, no attributable signal at all as well, and nothing more than what we expected to see in background patient population rates. And looking out over 6 years, what we don't see is we don't see any amplification of safety signals, okay? So, this gives us time to ferret out any of the rare events that may sneak up on us and make us look bad. And with Cosentyx, we see basically mirrored safety data compared to what we saw in previous studies. And marching out even further, what we see is the same thing in terms of adverse events. Once again, no signal for tuberculosis, no signals for malignancy here as well. And those treatment emergent adverse events tend to be pretty consistent amongst all these products and look very similar to what you saw in the Cosentyx studies with their drug. And the SKYRIZI data tends to be consistent with what we see in previous studies as well. No new safety signals were observed through that 52-week head-to-head study. Come on. I think I lost life to this. Can we advance me? I don't know what happened. Someone doesn't. Okay. So for Humira, the same holds true. The Humira and SKYRIZI data was consistent with what we saw from previous studies. Here's the ISI information, which I love to talk about because these are the landmines you might stumble across, because I like to talk about side effects into 2 different categories. The common, obviously you want to warn patients about all these common side effects, because chances are they might get them, okay? And then the rare and scary. Rare and scary is the real and perceived. What I don't like about this drug in this deck is there's not that much to talk about, which makes me seem like an industry hack, because I want to have that balanced conversation. I want to be the one that helps you navigate the waters to explain these events. There's just not that much to talk about. The same stuff that we look at, tuberculosis risk. What we see is that per the study guidelines, patients in the US were screened for tuberculosis. I recommend getting a QuantiFERON Gold annually. What we didn't see in any of the studies was any reactivation of latent tuberculosis. Administration of vaccines. I'm a pro-vaxxer. I believe in getting the COVID vaccine, getting the booster, and patients with biologic therapies, I feel are from the evidence-based real-world data from my previous talk, I can say that the rates of COVID in patients on biologic therapies tend to be consistent and actually lower than non-biologic therapies for psoriasis, but patients can get non-live vaccines, and the 3 approved vaccines in the US, none of which are live. Charting the course with SKYRIZI. So how's it administered? Well, it is a 150 milligram either auto-injector pen or pre-filled syringe. Day 0, 4 weeks later, then really every 12 weeks. Okay, 1 dose. So there was a company that used a slogan that said 361. And I think it really applies to this product a lot more than that other product, which is 361 days a year you don't think about your psoriasis. And this drug allows you to do that. After the loading dose, you're only getting 4 doses a year. And that's nice because there are some patients I like to have come in the office, get their injections, and coming in 4 times a year is not a big deal for them. Coming in more frequently tends to be a little bit of a drag. But as you know, this can be administered in office or at home. So AbbVie does a really good job of helping you help the patients. Okay, so we have these treatment goals where we want to get, high levels of clearance. We want to maintain that clearance, so that sprint to marathon component. We want great dosing. Obviously, it's just a nice value. You want a confidence in the therapy. You want a confidence in the company you work with that's invested in this space as well. Okay? You also want data that is derived from various different patient populations, a diverse, robust clinical trial data set that also has a number of other comparator studies, all of which this drug has. So SKYRIZI Complete, we have 4 clinical trial coordinators and 2 biologic coordinators, and I think they do a wonderful job. And I still feel that it is imperative that all of our patients enroll in this. And what we see on the upcoming slide is that patients do better when they're enrolled in these services. Okay, so I don't want to blow the next slide too early, but what we do see is that we've got great coverage because a drug that is great, that is not available, doesn't do any of us any good. So it's rather than being a recommender, where we can go back to being a prescriber. So if we want patients on this drug, chances are we can get them. We have that nurse ambassador program, which really just augments what you provide in your office, the field access specialist, the savings card for commercial patients, and a number of different resources, including apps and QR codes and things like that, to help patients navigate this process. So this is kind of that summary, which is it's that sprint that turns into a marathon. I like going backwards. I like to talk about the rapid response paired with durable efficacy. We have clear skin. Almost 60% of patients are clear at a year. Pretty awesome. 3 out of 4 patients at the primary endpoint in both of the Ultima 1 and Ultima 2 studies achieved PASI 90. We see that safety profile, which is nice because there's less to talk about. There's less to navigate and explain the risks because no is no. That means no. No risk for malignancy in terms of labeling warnings. No IBD signals, no depression, no candidiasis. No routine lab monitoring is required based on the drug. Now, don't be a dodo here, which means if a patient needs to have blood tests for other underlying conditions, do it. This doesn't mean this protects you from all blood draws. And then the convenience of, 4 times a year injections after that initial loading dose. So at this point, I will pause, open it up to any questions that you guys might have regarding this Dr. SKYRIZI. Yeah.